questions. If we are unable to deal with, every other time we're having cholera outbreaks in the country, and that's a concern. We have malaria in the country, it is a concern. We're also just having issues with our own health care, And Kenyans are asking, if we are unable to handle our very own, then why would we invite something we've never dealt with as a country and expose us? That aside, they say it was signed during Uhuru's time. Why are we seeing it being implemented now? Should this fight go back to Uhuru's time?
Politics sometimes is very difficult to understand, and the way things are communicated can also be very different, because as much as it's said that this was signed in 2015, 2022 renewal, but we know that the agreements that we are talking about currently is based on a G2G agreement between the Kenya government and the United States government. And I'm saying this because the Trump government, when they came into the office, they were out quickly to get away from WHO and to do away with the US aid, the system that was designed to handle such scenarios of cross-border infections and epidemics. And so therefore they were trying to deal with individual government, of which in Africa, I think Kenya is the country that works very closely with the US. And therefore, what we are dealing with right now is some document that was signed on 4th of December 2025 by the Prime Cabinet with the American government on the cooperation. It is just beyond the epidemic and the outbreaks. There's also aspect of the digital healthcare, where they're supporting the system that's being used. There's issues of health workforce. There's an issues of commodity that are there. The essence and the concern that we have as health sector, and that was all there with the public and the civil society, was the opaqueness of all the conversation. That when you have an agreement and you have, in fact, that was bringing an approval for the data, the issues of data in December, that there's need to bring people on board to understand and to see the implementation, so that accountability can be part and parcel of the conversation. When it is said that US has been supporting the healthcare of Kenya for over 60 years, with about 20 to 30% of the health budget that is being used in the country as partners, it is very clear to see that money, what value does it have to the Kenyans? And that can only be understood and can only be appreciated when it is transparent, there's accountability to it, and there's understanding on what value it's bringing.
Dr. As key stakeholders in the health sector, right, such decisions would inform involvement, would inform participation from you in terms of knowing what the government has put in place to secure its citizens from Ebola. What you're hearing right now is that the US government will handle its business on the side. But what happens if that gets to wananchi, if there is Ebola in the country today? Is there any plan that one would say, we have enough plan around handling Ebola, that even if the Americans are coming in, are setting up the thing on the side, we as a people, as the government of Kenya, as doctors, we are sure we are able to handle that? Is there any plan that you would say is concrete?
At the time that you were giving our statements, the only conversations in the country was about the quarantine that was being set up for the Americans. It was after the reactions of the public, the civil society, the unions, and the public generally, that the Prime Cabinet came and said that there are 17 other quarantines that are setting up for the country. And the Cabinet Secretary came out and said that they've been trying to do more of these particular isolation units, quarantine, and having plans to have the Kenyans protected. Yesterday at night, I saw the President, when he was in Wajir, he said that it's not only the Laikipia quarantine that is being talked about, there are other 23 others across the country. That, if that is the case, that's a lauded issue. That we must actually laud that. That's a good plan. But one thing we keep on insisting, it shouldn't just be that it is there when there's a reaction to our concern. We need to consume this information, and we need to be able to actually affirm that it is a reality before we come out gun-blazing about what is not happening. And number two, when we say we have over 23 of them, we need to see that, how are they equipped for the public? And how will they be able to help the public? Or are they just like those schools that were done during the COVID-19 time? That's something that we need to ask the government to actually explain. The other thing is that in terms of Because we know one thing: when we have Ebola cases, we need to have a very strong intensive care unit or support for the patient. Are they equipped to such an extent? The issue of the health workforce, which also was part of our statement, we have a shortage of healthcare workers across the country. That normally, if you go to the hospitals, the waiting time to see a doctor is always over 12 hours, sometimes even up to 24 hours, and that is both in the public and private hospitals. So. And even the time we have seen the ratio of the patient to of the nurse, the patient to the nurse is very high. It's very high. We've seen cases whereby because the nurses are not there in the hospitals, or there are very few, there's the cases whereby we lose the patients. So the reality is that when we are talking about the 23, we are talking about preparedness. Is the government? Has the government employed more health workforce, or have they put a plan to have more health workforce? Because ideally, Dan, when you have Ebola cases, the number of health workers that are needed to manage a case increases. You need like six nurses to manage one Ebola patient effectively. You need two physicians. So the health workforce is more. And that's why even during these outbreaks in Liberia or in West Africa, you realize there's a mobilization in African Union to have healthcare workers. Because when there are few, and they have a longer exposure to this particular that particular condition, themselves get exposed. That's why we have cases of healthcare workers when in DRC getting sick. So in reality, when we have these preparations for the quarantines, we need to see actions. We need to see employment of health workforce across to not only work in these quarantine points or to help to be preparedness, but to actually make healthcare functional. Because it is not possible to say we are preparing for Ebola when we can't manage choleras or we can't manage pneumonias.
Okay. And have any of those questions then been answered? Because you said that the statement came out